Hello, I'm Usmaan Ahmed. I'm currently an allergy and immunology registrar. I've done lots of respiratory in my life, and today we're going to be talking about some respiratory cases for PACES. Before we dive in, just tell you a little bit about our course. So, as hopefully you all know, we're running the BitePACES course. It's one of the leading courses that's held in London. We have two options. We have a one-day intensive course, and then we have a 4-day very comprehensive course, which goes through every station and has lots of someone's hand is raised. Not anymore. Okay. Goes through all the stations in great depth and has lots of patients to examine. At the moment, we are running our early bird discount. So the prices that you see on the screen are the early bird prices, and they are there for another couple of days. So please sign up. And just to note, if your exam date happens to be before the course is run, we will give you a full refund. The QR code is a link to our website. So let's talk about respiratory. As you may or may not know, the PACES exam changed recently. So now the first station, or station one, is the two parts are a respiratory station and then a communication station. Today we're obviously focusing on respiratory, and you will have 6 minutes to examine and then 4 minutes to present your findings and answer questions. Or as I say, at least 4 minutes, depending on how quickly you finish your examination. So I'm not going to go over how to do a respiratory exam, but I will pick up on certain aspects of it as we go through, and we'll go through a few cases and then some key tips to ace this station. Because I think respiratory is a station where it's pretty formulaic. There's not that many things they can ask you, especially in terms of what cases they can give you. And it's a station where you can definitely nail 20 out of 20. So the first thing just to flag to everybody is where you percuss and listen, because I think this is something that people often do badly. 4 places on the front, 4 places on the back, and you need to make sure that you go low enough, because in reality, most of the pathology will be at the bases and in the lower bases. So as you're practicing, just make sure you always go in the same order. So on the front, clavicles, and then 3 down the middle and 1 on the side, and same on the back. And you should be percussing and auscultating in exactly the same place. It should be symmetrical. I often see people who will be paravertebral on one side and then the other side, like 3/4 of the way across the person's back. So just please try and make it as symmetrical as you can, because then you will be able to compare like for like. And then the next thing just want to just quickly talk about before we get into the cases, is how to present. So I think there's two ways that they will like you to present in the exam. And until you get there, and depending on who your examiner is, you're not going to really know what they want. So I would practice both forms. So the first form on the left is like a full presentation. Essentially, what you're doing in this is making the most of those 4 minutes to get asked as few difficult questions as possible, to be honest. And so you talk through your exam. I examined a however many year-old man. There were or there weren't any paraphernalia of respiratory disease, and this is what I noted at the bedside. The patient looked well at rest, or they were tachypneic from the end of the bed, or whatever. Whether or not there were any peripheral stigmata, and then what you found on your chest examination. Whether there were signs of right heart failure, which is really important in a respiratory exam, because that shows that their disease is advanced, because essentially all respiratory disease at the end will cause right heart failure if it's bad enough. And then my findings are consistent with, and other differentials include and then you go from there and launch into the rest of whatever you want to say, which we can discuss. However, the other option is, and what they may just do to you, is say, just tell us your positive findings. In which case, if you try and give them your spiel, they will cut you off and say, no, no, we said just your positive findings. So you, in that case, say, I examined whoever you examined, my positive findings were. I think, and unless you practice, this can end up being quite a muddle for people because they get thrown. So really, really important that you practice this. And obviously, if you come on the course, we will have a mixture of answers and options to present. And the thing I would say to you is just make sure that even when you're doing a my positive findings were presentation, keep it structured. So just go in exactly the same way, but start peripherally or from the end of the bed and then get to the chest. Because the temptation is, my positive finding was these bibasal crackles, and then you forget all of the peripheral stuff that you had found on your examination, but unless you tell the examiner, they won't know, and they will dock you the marks. So I think it's easier just to go in order, to be honest, unless, yeah. And then you can say, my findings are consistent with, and other differentials include. Fine. So that is that. Now we're going to go on to some common cases. Before we do that, I'm just going to, no, actually, don't worry. We'll start with fibrosis. So fibrosis or interstitial lung disease is a really, really common PACES case. It's really easy for them to ask you. There's lots of patients for them to find, and most of them are very stable. And so it's something that's really easy to come up and really commonly comes up in a respiratory exam. And I think just the thing to say at this point is, as you will realize, respiratory and inflammatory disease / rheumatology are quite closely linked, and probably more than any of the other 4 stations, the system that's most linked with inflammation is respiratory. So the expectation in a respiratory exam is that you are looking for inflammatory disease in your peripheral examination. I know we talk about, you know, clubbing and their tar staining, which is obviously important, but when the PACES examiners, or when they pick these patients, they are looking for patients who you can synthesize an answer for. So the ideal patient will be somebody who has, for example, dermatomyositis with interstitial lung disease, or rheumatoid arthritis with interstitial lung disease. And so you just make sure that's important. That's part of what you're looking for when you're doing a respiratory exam. So in fibrosis or ILD, the examination findings that you would expect from the end of the bed, they should be short of breath generally. They might have a dry cough. Maybe they'll be on LTOT. There may be some medication around the bed, which we'll talk about later. Peripherally, they could be cynos, depending on the cause of the lung disease. There may be signs of inflammatory lung disease or rheumatoid hands, for example. If they've had steroids, they may have signs of steroid use. And then when you get to the chest expansion should be reduced bilaterally, which I think is quite a difficult sign to elicit in fibrosis, but definitely worth being aware of. And then obviously the fine end inspiratory crackles, which are there when you cough and don't change, are the hallmark of fibrosis. And they may have a dull percussion note, but in all honesty, unless they have really advanced fibrosis, you're not going to pick up a dull percussion note. And so it's better not to pretend that it's there when you've not picked it up. And I think the thing to say here is, if you hear those fine end inspiratory, Velcro crackles that there's good YouTube videos on, if you haven't heard it in real life, then you need to think at this point, when you finished your exam, that have I missed any cause of this interstitial lung disease? And so the thing that I just want to say now and I'll probably repeat again a few times, is all of the marks in the respiratory exam and like what the answer is when you listen to their back, basically, because that's where you auscultate, and that's largely where the signs will be. And that's, or if they've got an effusion, for example, when you percuss them, it'll be in their back. And that's the last thing that you do in your respiratory exam, basically. And so you just need to be aware and try and get through your examination quickly so that you can have a long time listening to their back. And then that way, if you still have a few seconds left, you can always go back and look for anything that you may have missed. I think that's a really important thing to remember, is that where the marks are to be found in terms of getting the answer right. And then some signs that you may find associated with the cause. So we talked about autoimmune disease already. And then, like, there's obviously the drug causes. So methotrexate in the context of them having some inflammatory disease. Or if they have an arrhythmia, you could think about maybe they'd be on amiodarone if their skin's gray, but again, rare to see. Then, so you've presented that, and then your differentials. So your differentials for bilateral creps are going to be fibrosis, obviously, bronchiectasis, but we'll talk about that soon, a bilateral pneumonia, or pulmonary edema. So that's how you would present. My differentials for this include whatever these for. And then in terms of if you think it is fibrosis or ILD, my differentials for the causes of this are, and then that will obviously depend on where you've heard the crackles. So if they are lower lobe predominant, then you're going to say my differentials include IPF, rheumatological problems such as rheumatoid arthritis, SLE, drugs such as methotrexate and bleomycin or asbestosis. Some causes of upper lobe predominant fibrosis include, and then you can go on to your upper lobe predominant, because maybe they have upper lobe and it's spread, or there's atypical, and then you can talk about them just in case, just to make sure you don't miss the actual answer. From this, so I think in terms of how much you need to know for this exam about these different conditions, is not that much. I think you need to have an extensive amount of knowledge. No one's going to really grill you on all the different types of hypersensitivity pneumonitis. But I think you just need to be able to answer a short question about it. So if you say, do you think it's a hypersensitivity pneumonitis, for example, you can give some examples: bird fancier's lung, farmer's lung, whatever. And that you know that it's hypersensitivity, so it's immune complex, and it's an immune complex mediated reaction, and that the management for that, for example, would be allergen avoidance and immunosuppression. Next, so you go into your differentials and then your investigations. So investigations in the context of someone with bilateral crackles or fibrosis would be, the way that we're going to break it down for all of these is bedside, bloods, imaging, and then special tests. So at the bedside, oxygen saturations, a gas, bloods, so your normal bloods, and then autoimmune screen, myositis screen, imaging, chest x-ray first, and then HRCT. And it's important to know that as the disease progresses, you get into honeycombing at the end. Early on, you would be reticular nodule ground glass change. And then special tests, so the spirometry, and the fact that it's a restrictive spirometry in IPF or ILD, and they have a reduced transfer factor. At this point, I just want to say that when you're revising, you may come across terms like UIP and NSIP. I think that they're not that helpful in the context of PACES. No one's really going to ask you about them. Clinically, people don't really talk about that in the respiratory world, and that's more a radiological finding, and this is a clinical exam. So personally, I'll just stay clear of those terms because they can just get confusing, and instead say it's an interstitial lung disease and it could fit into this, whatever, if you think it is. Other things to point out. So obviously you need to know what the answers will be in these like situations. So if you, in ILD, largely the ABG should show a type 1 respiratory failure. Where's my, oh, it's coming. And then management. So for all these ILD patients, and basically for all respiratory patients, conservative management will be smoking cessation or tell them not to smoke. Pulmonary rehab is usually helpful in almost all conditions. Annual flu vaccine, either one time or 5-yearly pneumonia vaccine. Like if you say those things, they're just like tell the examiner that you understand respiratory disease, because the medicines will change, but these things are always going to be the same. Treat any underlying cause in the ILD. If they've got hypersensitive pneumonitis, which will be difficult to pick up unless they have like a magazine of bird watching next to their bed or something, then avoid the exposure to the cause. LTOT, so you need to learn the criteria for LTOT, it's important. So which is a PO2 less than 7.3 or PO2 less than 8 or 8 to 7.3 to 8 with cor pulmonale or pulmonary edema. And then if they have IPF, which is basically clubbing plus bibasal cracks, you can talk about pirfenidone or nintedanib. Clinical trials exist, and then lung transplant, which would be the definitive management in these cases. Just to quickly talk about spirometry, which is a common question in respiratory stations, and they always like to throw in, what do you think their spirometry will be? Because it's an easy thing to ask and you're meant to know it. So this is basically a list of what other different causes are of spirometry findings. I think you probably know this, that these are the obstructive things are COPD, asthma, often in bronchiectasis, ILD is restrictive, and then all these non-parenchymal things. So neuromuscular disease, chest wall deformities, scoliosis, some pectus deformity. If they're obese, these will give you restriction. And then mixed picture. So in my PACES, they definitely asked me, give us a cause of obstructive and restrictive spirometry, as in mixed. And I think the most sensible answer is someone who has two pathologies, because in reality, there's a lot of obese asthmatics or obese COPD patients or people who have scoliosis and COPD. So those are the much commoner answers. And then if they really are pushing you to give an answer, then well, sarcoid apparently gives you both obstructive and restrictive pathology. So you can say that at the end, but I would lead with the fact that the most likely reason why someone has both is they have two things going on, even though it doesn't fit into the normal nice thing that people want to hear. Fine. All right, so onwards. Next, bronchiectasis. So this is your other differential for generally bilateral creps. From the end of the bed, these people are often cachectic, especially if they have like CF. They will have sputum pots around them. They will have a wet cough. They might have inhalers, and they get often short of breath. They are also clubbed, just like in IPF. And then on their chest, they will have coarse creps when they cough. So anytime you hear creps, make them cough. These ones should change a little bit when they cough because the mucus has moved around because they've coughed and they've cleared that area. And then when you move your stethoscope somewhere else and they have more creps, then that's kind of a telling sign that they have bronchiectasis. They may also have some wheeze, and that's just because the airways become constricted around the bronchiectatic areas, and so they get a little bit of wheeze and these squawks. And then they may have previously had IV antibiotics, so they may have line scars, central line or porticath. So definitely something to look out for. And if they've had, for some reason, they had a bit of focal bronchiectasis, or they had bleeding bronchiectasis that was uncontrollable, then they may have a scar from a thoracotomy. So something to think about. And so if you think things are in keeping with bronchiectasis, then your differential is going to be, when you see these people, you would say this person has CREPS. This could be fibrosis, bronchiectasis, pneumonia, but I think it's bronchiectasis, and etiologies of this include, and then the etiologies of bronchiectasis I'm not going to go into, but you just need to learn them. Essentially, they can be infective, they can be congenital defects, and these other things. In terms of what you're actually going to find in your exam, I mean, you're never going to know if they've had lots of infections. So, I mean, you obviously have to say it, but it's not going to be something to find on examination. If someone has CF, they will have line scars, or they will have a porticath, and they may have had some other kind of surgery in the past, and they'll usually be a younger person. Cartaginous, situs invertus. So if you hear a heart sound on the wrong side, then think cartaginous. But in reality, you're probably not going to guess that in your exam. Immunodeficiency patients, nothing really to see. Same with ABPA, same with HIV. The rheum, as we said at the beginning, always look for the rheumatological problems because they come up and they're the cause of basically most of the respiratory findings in an exam. And then yellow nail syndrome. I mean, if you see some of the yellow nails, think about it, but rare. Investigations in bronchiectasis. So nothing, bedside find, you can do SATs, bloods, normal bloods, inflammatory markers to look for infection, immunoglobulins to make sure they're not hypogamma, which is a cause, and then aspergillus IgE to look for ABPA or aspergillus indices. And imaging, so chest X-ray first, then HRCT, they have a signet ring pattern. And the reason for doing the HRCT is to see the extent and the distribution of the bronchiectasis, because it will help plan for management. And then some special tests, so lung function, which could be normal or could be obstructive. If you think they might have CF, or then a sweat test, and genetics. If you think they might have cartaginous, then a saccharin test, and genetics. And then always for these people, and anyone who's got a wet cough, you need to say that you want to do sputum cultures, and be specific. Sputum cultures for what? For micro, for bacteria, for fungal, and for AFBs, because these are the things that these patients can get and can cause significant morbidity. And they may say, like, why do people get bronchiectasis? And I think the answer to that should just be, these patients have chronic inflammation of the airways, which causes dilation and thickening, leading to chronic cough and bacterial colonization and infections. I think that's fine. And then management. So again, the conservative things we talked about. Bronchiectasis, because it's largely infection, is the main problem. Most of your treatment is going to be around infection. So it'll be having rescue antibiotics or using prophylactic antibiotics, or prophylactic nebulized antibiotics, depending on what bugs they're growing. The use of chest physio, mucolytics, carbamazepine, hypertonic saline. And then again, a definitive option is surgery, so double lung transplant, a lobectomy if they have a focal area of bronchiectasis, which is causing them problems. And I think it's useful to know the common pathogens that people get in CF and bronchiectasis, and just being aware that if you have Burkholderia, the prognosis is a bit worse because it's a difficult bug to clear. Fine. Nothing else I wanted to say here. And moving on. So, pneumonectomies and lobectomies. Another really common case to get in an exam, because these patients are generally stable and they're thankful that they no longer have lung cancer and have not died. so they're happy to come to exams. And so I think these are a bit challenging because you do all of your peripheral exam largely, and generally these patients are very well. So from the end of the bed, they look well. Peripherally, they may not have anything. I mean, they might have some clubbing if they had a previous, lung abscess maybe, or they had cancer. Or they may have some signs peripherally of cancer, tar staining, HPOA, but largely they probably won't have anything because their cancer, if they've managed to have surgery for it, is probably won't have been that advanced. Then moving on to their chest, they will have tracheal deviation, and the tracheal deviation will be towards the side of the pneumonectomy or the lobectomy. If somebody's had a lower lobe lobectomy, they really won't have any tracheal deviation. So just bear that in mind, because you might see the scar and be feeling for their trachea and think it's in the middle and then be a bit freaked out, but it's still, the answer may still be correct, that lower lobe lobectomies, you don't typically get tracheal deviation. Then their chest wall, so they will obviously have this, they will have one of two scars. They will either have the top right scar, which is a lateral thoracotomy scar, and this one's going into the back, so it's a posterolateral thoracotomy, which is largely what is the traditional way of doing a pneumonectomy or a lobectomy. Or they may have a VAT scar, which is much smaller. Some people may have more than one port, so just think laparoscopic surgery, but for their chest. They may have more than one port, and there'll probably be a little hole where the chest drain was, or mark where the chest drain was. So to just be aware that they may have smaller scars, and that doesn't mean they've not had a lobectomy. It's still possible that you can do a lobectomy like this. And so you need to really, when you're looking on your examination at their chest, and you put their arms up like a chicken or whatever, you have a really good look in their axilla and below their axilla to find out, are there any scars there? Because that's where the scars will largely be in these patients. Then when you're examining their chest, they'll have asymmetric chest expansion, their percussion note. So it could either be hyperresonant, which would be if they had a really fresh pneumonectomy, because there's nothing there yet. But with time, a pneumonectomy will fill with just fluid, basically, and it will become dull. So more likely than not, you'll have a dull percussion note over their pneumonectomy scar, and there will be no breath sounds, obviously, because there's no lung. So differentials. So differentials for the scar, which is basically what you found, would be lobectomy, pneumonectomy, a single lung transplant. So people can have single lung transplants, largely in COPD or fibrosis, or cardiac surgery, such as mitral valve repair. But largely, cardiac surgery will be anterolateral, not posterolateral. So low down your list. Then in terms of if you've gone for lobectomy, pneumonectomy, because that's what your findings, that's what your examination has found, you're going to say my differentials for causes of a lobectomy or pneumonectomy include either bronchogenic cancer, localized bronchiectasis, previous trauma, lung abscess, volume reduction surgery, or old TB. So in that list, the things that will give you that you would have a pneumonectomy for really are cancer or really bad trauma. For most other things, you would probably just end up having a lobectomy. But definitely, these things are just things to consider. The other thing to say here is that if somebody's had a lung transplant, then what will be different from a lung transplant to a lobectomy is there will be breath sounds. So if somebody has that scar, and they have breath sounds underneath it, then there's lung there. So go for a lung transplant as your answer, as opposed to pneumonectomy. And that's really important. So if you have a scar and breath sounds, it's either going to be lobectomy for some lobe, or it's going to be lung transplant. It can't be anything else really, or cardiac surgery. And then you'd say to further evaluate, so bedside SATs, imaging. So the imaging on a chest X-ray will be, in a lobectomy, will essentially be normal, right? You won't really see much other than the hemidiaphragm will be raised. In a pneumonectomy, they have a whiteout. And then the important thing for these cases is being aware that the reasons why people, the criteria for having a pneumonectomy or lobectomy. So thoracic surgeons, you may have come across them. They are happy to operate on people, but only if they think they're going to recover with reasonable lung function. So the pre-op evaluation for these people is they have to have lung function tests done. So that's an important thing that you should say, that they will have had to have had done. Lung function in their evaluation for surgery. Their performance status is important, the tumor staging is important, and the MDT outcome is important. So if you've got a case with lung cancer, or if they asked you, which I think is quite a reasonable thing to ask, because frankly, in these cases, there's not really much they can ask you. It's quite a boring case, pneumonectomy and lobectomy. So they may say to you, if this person has lung cancer, what needs to be worked up, or what workup do they need to have before they can undergo this procedure? Then the things that you need to mention are, they need to have lung function tests, or even you can just say just spirometry, and they need to have, and then you should know the criteria. So FEV1 of more than 1.5 liters and more than 2 liters for pneumonectomy. They need to have a performance status assessed. Their tumor needs to be staged, and they need to have an MDT outcome from the lung cancer MDT. Yeah, I think that's all I want to say there. Then, as a reasonable segue, just to talk about lung function and the way that you word that in an exam. So, for fibrosis, bronchiectasis, COPD, asthma, this case, you are gonna, if you get the chance to say what investigation you want, you would probably say, I would like to do some lung function tests. And I think it's important that you are aware of the different types of lung function tests, because that's something that they will kind of expect you to know. And it may be better to, rather than say lung function tests, to say the ones you want. Or if you don't want to do that and you're happy to just say lung function tests, then we have an understanding, because it's an easy question for them to ask. So for everything that we've discussed so far, basically, the lung function test that we are asking for is spirometry. Spirometry is, you get an FEV1, you get FVC, and you get your FEV1 to FVC ratio. That's spirometry. And so that's basically gives you, is it obstructive, is it restrictive? And that's it. Which is helpful, you know, like if you want to decide, does this person have COPD or IOD? It's helpful. Next, the next thing is transfer factor. So if you are trying to decide how bad their ILD is, or for some other reason you want to know what the transfer factor is, because it can be helpful, then you ask for transfer factor, or KCO. Largely the time that is useful is in ILD, so that's when you would ask for that. Then the third thing, the last two things are FeNO, which you probably all are aware is used in asthma, so it's fraction of exhaled nitric oxide, and that tells you how inflamed someone's airways are. So FeNO, so that's good for asthma, or if you're in a case where you're differentiating between COPD or asthma, FeNO is helpful. And then the last thing is lung volumes. So that's when you get like total lung capacity, functional residual capacity, vital capacity, all of these things. I don't think anyone's going to ask you about that in PACES. I think in reality, you probably don't ever need to mention that. And I wouldn't like go digging unless you really enjoy rest. And then the last thing that you may come across is a 6-minute walk test. So 6-minute walk test is to see whether someone desaturates over the course of 6 minutes. And it's useful in people who've got interstitial lung disease or people who've got COPD and they're like worried about LTOT. So that's just another thing that exists. But I mean, it may be a question that they ask you. I don't think it's something that you need to put into your presentation personally. Good. All right. So next, so pleural effusions. So another exam favorite. These patients from the end of the bed, often short of breath. And then you need to have in your mind what the causes of pleural effusions are, because then that's what you're going to be looking for on your examination, obviously. So peripherally, they may have some signs of lung cancer, which is a common cause, or some cancer, because often pleural effusions can be malignant. Inflammatory disease or failure. Tracheodeviation. So if someone has a large pleural effusion, they should have tracheodeviation away. In reality, is somebody going to come to your exam with such a big pleural effusion that they've got the trachea deviated away? It's unlikely, but just need to be aware of. And that's what, you know, and I think the thing is, some of these things, even if you don't see them, the examiners like asking you, okay, let's say they have a pleural, in this person's pleural effusion, if it was bigger, what would you expect to find what would expect to happen to their vocal resonance, which you'll come to in a second, for example. So even if it's something that you're unlikely to see, it's important to know what you should be expecting, because examiners like asking these questions. When you're looking at their chest, so you're looking for any signs of chest strains, previous chest strains. Have they had a VAT surgery before? So that small scar that we talked about. Do they have an indwelling pleural catheter, which we'll talk about? And then percussion. So do they have a stony, dull percussion note? That's the classic pleural effusion finding. The breath sound should be reduced where the percussion is dull and where the fluid is. And they may have crackles or bronchial breathing above if the lung is consolidated. So when it gets pushed together, normally you get some crackles or bronchial breathing. And they'll have reduced vocal resonance at the over the effusion. And I think if you think someone has an effusion, what you should do to make it look very clear to the examiner that you know that they've got an effusion is you listen in your normal 4 places, as we discussed at the beginning, and you percuss in those places. And where it goes dull, you then percuss in like a nice upwards, go up 1 space at a time until the percussion stops being dull. And that way you can have an idea of, well, the pleural effusion goes up 3 intercostal spaces. And that's a nice way of showing the examiner that what you're looking for. And in your own mind, thinking like this is a big effusion or this is a small effusion or whatever, depending on what you find. And you can do the same with the auscultation. So where it's absent or where it's reduced, and then where it becomes normal. And I think that's a really nice thing to do. And it's a nice habit to get into when you're examining patients who've got pleural effusions. The other thing I'd say just to be aware of at this point is that, again, another thing that I've not put on this list is chest expansion. So technically your chest expansion should be reduced on the side of your effusion. But again, rare to see it because you'd have to have a very large effusion, but just something to be aware of. And be aware that their peripheral signs may not just be of lung cancer, maybe they could have any cancer. Malignant pleural effusions could be from lots of things, which we'll talk about in a second. Now, if someone has a dull lung base, so your differentials are they've got consolidation, so infection largely, they have collapse, they have pleural thickening, or they have a raised hemi diaphragm. And the difference between these is in consolidation, they should have crackles. So their percussion note may be dull, but they should have crackles, not reduced breath sounds. And their vocal resonance should be increased. If they have collapse, then that means that there's no air going into that space. So there should be absent breath sounds, and the trachea should not be deviated away, it should be deviated towards. Pleural thickening, then they shouldn't have any tracheal deviation as well. Their breath sounds may be normal. And if they have a raised hemi, then could either be phrenic nerve palsy or it could be hepatomegaly, essentially. And it's just something to be aware of as a differential. In reality, in an exam, you're not going to go looking for the liver in a respiratory exam, because I don't think there's any value in doing that. And so when you're presenting my differentials for causes of a pleural effusion, and it will include the following. So break it down, nice structure, transudates, which would be different failures, nephrotic syndrome, Meague syndrome as your out there answer, and then exudates, malignancy, infection, or systemic inflammatory disease. And I think it's important just to be aware of mechanistically why they're different. So in like cardiac failure, the reason that they have a pleural effusion is because their venous pressure has gone up and so the fluid's going out. Whereas in nephrotic syndrome, they've obviously lost all their albumin, same as in cirrhosis, they've got low albumin, and so they don't have the oncotic pressure to pull the fluid back in. And then in exudates is largely the inflammatory process that's causing you to, it's either inflammatory, or it could also be like some kind of erosive process that's causing you to have so much pleural fluid in that space. And same with inflammatory disease. And then to evaluate this further, I would bedside bloods, imaging, special, as we've talked about before. The important bloods for these people would be their glucose, their protein, thyroid function because of the Meigs, their BNP if you think they've got a failure. The glucose and the protein are because when you're then going to do your pleural aspirate, that's what you need to compare your pleural fluid to, an LDH to. On chest x-ray, so you can say on chest x-ray, you would expect to find the first sign would be blunting of the angle. And then as it gets bigger, then increased opacity at that base. And if you think that it might be a cancer as the underlying cause, then you would ask for a CT chest or CT cap, or biopsy of the pleural space, or a bronchoscopy, which we'll talk about in a minute. And then in terms of special tests, well, this obviously is ultrasound-guided pleural aspirate. So you're going to send that for biochemistry, which is glucose, protein, LDH, from micro to look for any bugs or TB, cytology to look for cancer, and then the pH if you're worried about empyema. Fine. And what you're looking for when you aspirate the fluid is it a transudate or is it an exudate? So you just need to learn this. Transudates have a protein less than 25, exudates more than 35, anything in the middle, use Light's criteria, which you need to learn. And then be aware that empyemas is basically passing the space, so pH less than 7.2. And that is the time when you have to drain it. So management of an effusion will be find and treat the underlying cause. If they're symptomatic with their effusion, then you can offer either therapeutic aspirate or a chest drain. And if they have recurrent pleural effusions, then the options are pleurodesis or indwelling pleural catheter, essentially. And just at this point, just to say, if the questioning goes down the route of this being a malignant pleural effusion, then I think it's important to have some kind of understanding of if you think this is a malignant pleural effusion. The question is then, how do you work this person up? Or what investigations do you need to have? And so that's important that you just know that basically the things that they will need to have if you think it's a malignant pleural effusion is firstly the aspirate that we've already done with the cytology, then a CT scan of the chest abdo pelvis, so to look for a tumor, because as we've said, it may not be a lung cancer, could be a lymphoma, or it could be a breast cancer. So CT cap, a PET scan to look for any disseminated disease. And then the last thing is whether you need to do any more tissue sampling. So I think the thing to say in that would be that although the cytology is your first port of call, it's not very diagnostic. Maybe 40% of people get a diagnosis from a cytology. So they'll need to have more tissue taken. So either, depending on where the lesion is, so some other sampling of whatever lesion they have. And I think that's a useful thing for you to know, because that's something that's easy for them to ask, especially because most of these cases could be lung cancer in some way. Fine. Then I just want to talk about a couple of more things. So COPD. I don't think it's that common to get COPD as a case, but I think when they are struggling to find a patient, or if somebody cancels, then they may just bring the COPD person because they're easy to talk about and it's quite common. And loads of people have COPD and you just need to scatter some inhalers and they often have a bit of a wheeze. So I think it's definitely something that if it comes up, you should be able to get really excellent mark on. Examining them, I mean, they probably have some tar staining, they won't be clubbed. And peripherally, there's not going to be very much more. Maybe they'll have a flap if they've got CO2 retention and a bounding pulse. And then when you listen to their chest, maybe they'll have a barrel chest and some wheeze. But I think in terms of the actual presenting them, once you're presenting them, you can talk about the differentials for wheeze. So it's easy for you to say, I think they have COPD. Some differentials for wheeze would be asthma, viral-induced wheeze are the most common, cardiac failure, and then GPA or RA is lower down with the obliterative bronchiolitis. And then in COPD, like that's something that I'm sure all know, that the investigations in a chest X-ray will be hyper expanded. The ABG, they may have type 2 respiratory failure. Their bloods will essentially be, if you're going to do bloods on them, maybe you do alpha-1 antitrypsin. You can check their full blood count to make sure they're not anemic. You can check their BNP to see they've not got secondary heart failure. And then imaging, chest X-ray, maybe a CT if you want to do some cancer surveillance. And then special lung function tests, spirometry to evaluate how advanced their COPD is. So I think that's something that's quite nice to think about. And then just in terms of the other important things, our management, so like we've already talked about, in terms of conservative management, and just being aware that in terms of the things that will improve mortality, the things that improve mortality are smoking cessation and LTOT, if it's indicated, essentially not inhalers. And then having some understanding that surgery does have a role for some patients. So you could have a balectomy, endobronchial valves, volume reduction surgery. Fine. Then, so just before we finish, so some general things just to remember in respiratory. So as we touched on earlier, the answer is in or on the chest at the back. So what I mean by that is you're going to find the answer when you auscultate the back, basically. And so this leads on to that question of how do you examine a person? Do you start at the back or do you start at the front? Personally, I think that from my experience in PACES, unlike in medical school finals, no one's going to say to you, stop your exam because you've examined their back. You know, you're always going to have to examine the front and the back. And when you're practicing, you should be in the habit of examining the front of the chest and the back of the chest. And for that reason, I think it looks slicker to do front first and then back last, just from a purely aesthetic point of view. And, you know, this exam, you're meant to do the exam beautifully. So I think that's the way I did it. And I think that's the way one should do it. And that means that by the end, you've figured out what's going on. You hear the you auscultate in the back. You know where the craps are, or whether they've got an effusion or whatever, and then you can put it all together. If you have time left, and I think I personally think the way to do it is to get there quite fast so that you can have a good time to listen to their back, and then you can always go back. Like, no one's going to think your exam is less slick because you finished and then you've gone back to look at their hands. Once you finished, and then you can do whatever you like after that, and they don't think less of you. So in my opinion, do the peripheral stuff, obviously examine properly and look for things, but make sure you get to their chest auscultation at the back as quickly as you can so that you can have a good listen and listen properly and find out what's going on. Symmetry is key. We've already talked about where to listen and where to percuss, and that's really, really important. You do not need to do tactile parameters and vocal parameters. Just do one, wherever you prefer. Some people prefer doing tactile because they can do them at the same time like this. I've always done vocal. It doesn't really matter. You know, it is what it is. If you ever hear creps, get the patient to cough. Always finish your exam by looking at their calves and their shins to make sure they're not fluid overloaded, because core pulmonale is important, and just remember that. And when you're presenting, if they have features of core pulmonale, it's important to say that they have features of right heart failure, because it shows that the disease is advanced, which is a good, and it's important to show the examiners that you understand that. Perfect. Okay, that's my last slide. Before we take questions, which you can put in the chat, just to let you know, these are upcoming webinars. So we've got one on Saturday, how to ace your